Dear learners, in the previous module entitled Public Health and Population Interface, we have already come across a few preliminary concepts relating to public health. There, we have also seen the interlinkage between population and public health. Now, we shall discuss the 29th module of the MOOC course entitled Issues of Health and Healthcare in India. As we have already stated, this module discusses certain issues of health and healthcare in India. Here, we shall basically discuss a few basic concepts of health and healthcare. We shall also briefly discuss the healthcare system in India. We shall then discuss the recent trends in the major health indicators in India. Then we shall look into certain underlying socio-economic issues affecting India's health sector. Apart from that, we shall also briefly discuss the state-wise disparities in health indicators in India. Dear learners, the basic objectives set in this module are to discuss the concepts of health, healthcare, to briefly introduce the healthcare system in India, to discuss the recent trends in the major health indicators, to outline the underlying socio-economic issues affecting India's health sector, and finally, to discuss the state-wise disparities in health indicators in India. Now, health is a very broad concept. The World Health Organization, WHO, defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The difference between healthcare and health is that healthcare is a means to achieve good health. Thus, good health is the ultimate goal, and healthcare is the means to achieve the goal. Now, looking into the healthcare system in India, historically, two guiding principles have served as the foundation for India's commitment to health improvement. The first is state responsibility for healthcare, and the second is universal access to free medical treatment, not only for those who cannot afford it. During the Indus Valley civilization, mentions may be found of Arogya as representing holistic well-being, which demonstrates the great tradition of public health that our nation was founded on. The healthcare delivery system faces significant challenges in today's very diverse society. Among the global challenges India faces today, the country is acting towards fulfilling the World Health Organization's global commitment to achieving universal health coverage by 2030 under the Sustainable Development Goals SDG Target 3.8. This target mandates achieving universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Significantly, the Indian government has made a considerable effort to implement policies and programs that align with the goals outlined in the Sustainable Development Goals. These goals include lowering the under 5 and neonatal mortality rates, guaranteeing universal access to healthcare, and boosting the hiring, training, and retention of healthcare professionals. It has been seen that in the recent times in India, the population's changing health needs, the government's increased fiscal capacity as a result of countries' rising economic growth, and the growing frequency of catastrophic spending due to healthcare costs have made policy and programs responses that reach everyone in a comprehensive, integrated manner necessary. The Indian government, under the National Health Mission, has made a concentrated effort to involve all pertinent sectors and stakeholders in the march towards universal health coverage and providing high-quality, reasonably priced healthcare to everyone. Maternal mortality ratio and child mortality ratios have significantly decreased as a consequence of Government of India's coordinated and persistent efforts. Due to its continuum of care strategy that covers all life phases, India now has one of the largest healthcare networks in the world, serving every mother and child in the nation. It should be noted here that the epidemiological shifts occurring in India will increase the need for further data on healthcare planning in order to support well-informed decision-making for the effective delivery of healthcare services. The union and state governments are the primary suppliers of health information. The sample registration system, civil registration system, and census are examples of indirect sources. On the other hand, the official statistics and sample surveys, which are often based on data that is already gathered for any official project, are considered direct sources to obtain relevant information on health and healthcare system in India. In the recent COVID-19 pandemic, we have experienced the burden the healthcare system has to bear in offering time-bound, effective and efficient delivery of healthcare services across the country. Studies also have shown that global health is about to enter a new age. India is not an exception to that. Rapid health transition is occurring across the nation, involving changes in diet, nutrition, and socio-cultural practices, in addition to demographic and epidemiological shifts. This has direct and significant effects on the formulation of health policies and programs. On this background, we shall discuss the performance of health sector in India in the recent times in terms of certain major health indicators. Apart from that, we shall also discuss certain socio-economic issues faced by the health sector in India. The state-wise disparities across different states in India will also be looked into. We shall now start with discussing the recent trends in the major health indicators. The data from the 5th round of National Family Health Survey, NFSS 5, conducted during 2019-21, indicates that the healthcare network in India is one of the biggest globally. The improvement in a few key health-related variables is indicative of an effective health approach. This has been summarily presented in table 29.1. So here we see table 29.1 and we have seen here in two parts. In your text you will get in one part. Table 29.1 indicates that India has made progress in certain health indicators like current use of family planning method, mothers who had at least 4 antenatal care visits, institutional births, neonatal mortality rate, infant mortality rate, under 5 mortality rate, children aged 12 to 23 months fully vaccinated based on information from earlier vaccination card or mother's recall, and children under age of 6 months exclusively breastfed. On the other hand, certain followed indicators like children under 5 years who are stunted in height for age ratio, children under 5 years who are wasted in weight for height ratio, and children under 5 years who are underweight in weight for age ratio has lowered compared to the previous NFSS study round, hence shows improvement. Another improvement noticed in the NFSS 5 round is increase in the number of households with any usual member covered under a health insurance or financial scheme. On the contrary, certain concerns are there in the indicators like children under 5 years who are overweight in weight for height ratio, and B, women who are overweight or obese in BMI index, which is more than 25 kg per meter square, and men who are overweight or obese in BMI more than 25 kg per meter square. Such achievements recorded by India towards improving the health condition of women and children is the outcome of coordinated efforts under the Reproductive, Maternal, Newborn, Child, Adolescent Health plus Nutrition RMNCAH plus N program, along with other policy and program-based measures adopted from time to time. India has successfully met the major milestone of bringing the maternal mortality ratio MMR below 100 per lakh live births by 2020, as stated in the National Health Policy 2017, by bringing it down to 97 per lakh live births in 2018-20 from 130 per lakh live births in 2014-16, according to data from the sample registration system. Thus, the SDG aim of lowering MMR to less than 70 per lakh live births by 2030 has already been met by 8 states of India. These include Kerala, it is 19, Maharashtra, it is 33, Telangana, it is 43, Andhra Pradesh 45, Tamil Nadu 54, Jharkhand 56, Gujarat 57, and Karnataka 69. Significantly, it should be noted here that India's efforts to increase health service coverage through strengthening health service delivery quality assurance, RMNCAH plus N, human resources, community processes, information and knowledge, drugs and diagnosis, supply chain management, and through other programs and policy measures adopted from time to time, etc., have resulted in a further decline in the infant mortality rate, under 5 mortality rate, and neonatal mortality rate, among others. This may be noticed from the declining trend of these mortality indicators as shown in table 29.2. So here is the table 29.2. Here we see the data for 2014, 16, 18 and 2020. Now let us look into the major achievements recorded in a few reproductive and child health indicators in the recent times. We begin with infant mortality rate. We have already known that infant mortality rate is defined as the number of deaths of children under 1 year of age expressed per 1,000 live births. It is a crucial indicator of a community's physical well-being. Preserving newborns' lives has long been a concern in social policy, public health and humanitarian efforts. Essentially, high IMR often indicate unmet health needs in sanitation, medical care, nutrition and education. The trend of IMR in India in total and in urban and rural areas has been shown in figure 29.1. Here is the figure 29.1 and here we see trend of IMR in India during 1994 to 2020 as total, rural and urban. Figure 29.1 shows that IMR in India as a whole, shown by the top line, has come down to 28 in 2020 from 74 in 1994, a decline of 46 points over the last 27 years. The corresponding decline in rural IMR, shown by the bottom line, has been to the tune of 49 points from 80 in 1994 to 31 in 2020 against a decline of 33 points in urban IMR from 52 in 1994 to 19 in 2020, as has been shown by the middle line. Next, we shall look into the maternal mortality ratio, MMR. Maternal mortality ratio is defined as the number of maternal deaths during a given time period per 1 lakh live births during the same time period. Regardless of the location or length of the pregnancy, the maternal mortality rate is the number of maternal fatalities per 1,000 live births that result from pregnancy or pregnancy termination. Thus, the danger women face when they become pregnant is represented by the maternal mortality rate. Some of the recent facts relating to MMR are as follows. Nearly 800 women died from pregnancy and childbirth related avoidable causes per day in 2020 globally. In 2020, a mother died approximately every 2 minutes. MMR decreased by almost 34% globally between 2000 and 2020. In 2020, low and lower middle income countries accounted for about 95% of all maternal deaths. While pregnancy-related mortality in India have historically been rather high, new data indicates the country's MMR has decreased. The sample decision survey data is used in India to assess the rate of maternal death. Thus, in the recent times, MMR has significantly come down from 130 in 2014-16 to 97 per lakh live births in 2018-20. NFS's 5-round data shown in table 29.1 also indicates that compared to the previous period, certain progress has been noticed in the maternity care indicators. For example, mothers who had received at least 4 antenatal care visits have increased from 51.2 to 58.1% between NFS's 4 and NFS's 5 rounds. Similarly, having done ultrasound testing during pregnancy has increased from 61 to 78% during this period. The significant improvements in the health indicators as seen in table 29.1, however, often covers up a few important socioeconomic issues faced by the health sector across certain socioeconomic broad parameters. Thus, in this section, we shall basically focus on a few basic reproductive and child health indicators to understand various socioeconomic issues faced by the health sector of India. Figure 29.1 shown earlier indicates that there has been significant decline in IMR in both rural and urban areas. However, IMR is still higher in rural areas compared to the urban areas, though the gap between the urban and the rural areas are declining. Notably, improvement in IMR also an indicative of overall improvement in sanitation, medical care, nutrition and education in the country over the years. Similar to the decline in geographical disparities, IMR also has shown decline in gender disparities. Figure 29.2 shows this. Here we see that IMR for female has remained all through the years high. However, in 2020, IMR across two genders recorded the same level. So here is the figure 29.2 showing IMR with reference to gender in the years 2017, 18, 19 and 20. We have already stated that maternal mortality ratio has significantly declined in the country. However, it is still very high in several states. This has been shown in figure 29.3. From figure 29.3, it is seen that in certain states like Assam, Madhya Pradesh, and Uttar Pradesh, MMR is above 150 points. In other states like Orissa, Punjab, Bihar, Haryana, Rajasthan, and West Bengal, MMR is above 100 points, though comparatively lower than the above three states. As we already stated, most of such mortality cases are actually preventable. It may be argued that in order to promote maternal health, it is necessary to identify and address social and health system barriers that prevent women from accessing high-quality maternal healthcare services. Now, in the following, we shall look into certain issues that can be analyzed from certain health indicators. Let us begin with ANC care visits. Now, ANC care visits. Use of a skilled provider for ANC services is higher in urban areas, 92%, than in rural areas, 83%. Women with more education or wealth are more likely to use a skilled provider for ANC. Younger women and women with a fast birth are also more likely to use a skilled provider. Protection against neonatal tetanus. Protection against neonatal tetanus increases with education and wealth. Ultrasound tests are more common in urban areas among women with more education and for women in higher wealth households. Women with no sons are likely to have an ultrasound test and are more likely to have a son if they do. Now, delivery services. Institutional deliveries and skilled assistance during delivery are more common in urban areas among women with more education and in higher wealth households. Regarding C-section deliveries, C-section or cesarean deliveries are more common among fast births in private sector health facilities in urban areas and among more educated and wealthier women. Now, regarding postnatal health checks, women who deliver in a health facility are more likely to receive a postnatal health check within 2 days of delivery, and women with more education or wealth are more likely to receive a postnatal health check. Regarding postnatal health check for newborns, newborns delivered in a health facility are more likely to receive a postnatal health check within 2 days of birth. Newborns of more educated mothers are more likely to receive a postnatal health check. Of vaccination of children, the percentage of children aged 12 to 23 months who have received all basic vaccinations increased from 62% in 2015-16 to 77% in 2019-21. Muslim children are less likely to receive all basic vaccinations. Children of first birth order with more educated mothers or from higher wealth households are more likely to be fully vaccinated. Now, treatment of diarrhea. Urban children with diarrhea are more likely to receive fluid from an ORS, oral rehydration solution packet. Children in households in the lowest wealth quintile are less likely to be given ORT, oral rehydration therapy. Regarding disposal of children's stools are more likely to be disposed of appropriately in households with improved toilet facilities, in urban areas, and in households with more educated or wealthier mothers. Utilization of Integrated Child Development Scheme. Rural children are more likely to receive any services from AWC, Anganwadi Center, than urban children, and services during pregnancy and while breastfeeding are utilized more in rural areas than in urban areas. Child malnutrition. The prevalence of undernutrition is almost the same among girls and boys, but stunting is higher among children in rural areas and those born to thin mothers. 46% of children born to mothers with no schooling are stunted compared with 26% of children born to mothers with 12 or more years of schoolings. The prevalence of stunting decreases steadily with an increase in wealth quintiles from 46% of children in households in the lowest wealth quintile to 26% of children in households in the highest wealth quintile. Anemia prevalence in children. Overall, 67% of children had some degree of anemia. Anemia is more prevalent among children under age of 35 months and among children of anemic mothers. Anemia prevalence in adults. 57% of women and 25% of men aged 15 to 49 years in India are anemic. The prevalence of anemia is consistently high in almost all subgroups of women and above 20% for almost all subgroups of men. Anemia varies by maternity status, schooling, wealth, and location. Now, looking at the status disparities in health across the states in India, we see that it is prevalent in most of the health indicators. While such state-wise comparisons are available across a range of health indicators, we shall here consider a few maternity care related health indicators as shown in table 29.3. Here in the table 29.3 we see in 4 parts, but in text you will get in one table. Here we see mothers who had antenatal checkups in first trimester, mothers who had at least 4 antenatal care visits, then mothers whose last birth was protected against neonatal tetanus, then mothers who consumed iron and folic acid for 100 or more days when they were pregnant, and mothers who received postnatal care from A&M, midwife, other health personnel within 2 days of delivery. So these 5 indicators we have seen in table 29.3. And these are the different states. Table 29.3 shows the performance of Indian states on 5 maternal and neonatal health indicators. All states perform well in protecting mothers' last birth against neonatal tetanus with 92% coverage nationally. For postnatal care within 2 days of delivery, most states perform adequately except Meghalaya and Nagaland. However, only 2 states, Kerala and Lakshadweep, had more than 90% of women with antenatal care in the first trimester, and 59% of women had 4 or more ANC visits. In this case, certain states like Arunachal Pradesh, Bihar, and Meghalaya perform very poor. They only marginally cross the 50% mark. As shown, NFSS 5 data also indicates that overall 82% of women received IFA tablets, but only 44% took them for at least 100 days. Here again, certain states like Arunachal Pradesh, Bihar, Nagaland, Uttar Pradesh, and Ladakh perform very poor. They could not even record the 25% point mark. Again, Nagaland performed the worst with just 10%. The data highlights the need for targeted interventions to improve maternal and neonatal health outcomes in Indian states. Now let us discuss the summary of this module. We have discussed health is a very broad concept. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The difference between healthcare and health is that healthcare is a means to achieving good health. Thus, good health is the ultimate goal, and healthcare is the means to achieve that goal. Historically, 2 guiding principles have served as the foundation of India's commitment to health improvements. The first is state responsibility for healthcare, and the second is universal access to free medical treatment, not only for those who can afford it. In the recent times in India, the population's changing health needs, the government's increased fiscal capacity as a result of the country's rising economic growth, and the growing frequency of catastrophic spending due to healthcare costs have made policy and programs responses that reach everyone in a comprehensive, integrated manner quite necessary. The Indian government, under the National Health Mission, has made a concentrated effort to involve all pertinent sectors and stakeholders in the march towards universal health coverage and providing high-quality, reasonably priced healthcare to everyone. Maternal mortality ratio and child mortality rate have significantly decreased as a consequence of the Government of India's coordinated and persistent efforts. Due to its continuum of care strategy that covers all life phases, India has one of the largest healthcare networks in the world, serving every mother and child in the nation. It should be noted here that the epidemiological shifts occurring in India will increase the need for further data on healthcare planning in order to support well-informed decision-making for the effective delivery of healthcare services. NFSS data indicate that India has made progress in certain health indicators like current use of family planning method, mothers who had at least 4 antenatal care visits, institutional births, neonatal mortality rate, infant mortality rate, under 5 mortality rate, children aged 12 to 23 months fully vaccinated based on information from either vaccination care or mother's recall, and children under age 6 months exclusively breastfed. Such achievements recorded by India towards improving the health condition of women and children is the outcome of coordinated efforts under the Reproductive, Maternal, Newborn, Child, Adolescent Health plus Nutrition (RMNCAH plus N) program, along with other policy and program-based measures adopted from time to time. There are wide disparities in performance in health indicators across different states and regions of India. Last but not the least, different health and nutritional statistics in India reflect social and economic inequalities. Research indicates the evident association of appallingly low health status with poor, female, gender, level of education of the pregnant woman, rural place of residence, wealth quantile, tribal ethnicity, scheduled caste, and specific minority groups. This means that social, economic, and political system that produce social stratification based on factors including gender, race, of ethnicity, education, wealth, and occupation pose serious challenges to effective implementation of public health services in India. Essentially, this calls for analyzing the interlinkage between health and other social determinants like education, gender, wealth quantile, religion, caste, and community, etc. in a more effective way. Without proper understanding the social determinants in health outcome, the medical interventions alone are less likely to improve the health scenario of the country in any significant way. Thus, proper policy interventions need to be undertaken for improving the overall health indicators. With this, we conclude this module. In the next module, we shall continue our discussion on health issues in India. In that module, we basically look into morbidity trends and patterns in India. Thank you.